Let's dive straight into the clinical decision tree for upper limb musculoskeletal presentations. We are starting high level here with regional pain algorithms. On test day, your reflexes literally have to be hardwired to instantly evaluate trauma versus overuse, pinpoint the pain location, and sniff out any sensory loss.
So what are your crucial pivot points? It all comes down to range of motion, weakness, and mechanism. Here is the golden rule. If passive range of motion is totally normal, but active is decreased, you are looking at a tendon or muscle issue. But if both are decreased, that screams joint pathology. From there, sensory loss tells you exactly which nerve is involved, and provocative maneuvers will isolate the exact tendon. You figure all of this out before you even think about ordering a single scan.
Okay, moving up to the jaw for a second. Let's talk about temporomandibular joint, or TMJ disorder. These patients are going to present with unilateral morning headaches, maybe some ear pain or tinnitus, and their facial pain will specifically get worse when they move their jaw. If you look closely during the exam, you might notice tooth wear. That's your classic, undeniable physical evidence of bruxism, or teeth grinding. The diagnosis is entirely clinical. Management? Keep it super conservative. Educate them on avoiding triggers, suggest a soft diet, get them a dental splint for the grinding at night, and throw in some NSAIDs like naproxen.
All right, picture this classic test day scenario. A neonate presents with an extended elbow, a pronated forearm, and a flexed wrist right after a difficult delivery involving shoulder dystocia. Here's the million-dollar question. Is their grasp reflex intact? Yes, it is. And that intact grasp reflex is your absolute dead giveaway for Arab Duchenne palsy. Let's see exactly how we differentiate this from the other major brachial plexus injury. This cleanly separates the two major neonatal brachial plexus palsies. Arab Duchenne gives you that classic waiter's tip posture. You'll see decreased Moro and biceps reflexes, but like we just said, an intact grasp. Now, Klumpke palsy, that presents as a claw hand. The grasp reflex is completely absent, and you'll almost always see Horner syndrome, so ptosis and meiosis. Interestingly though, in Klumpke, the Moro and biceps reflexes actually stay intact. Now, what's the prognosis for both? Pretty good, actually. About 80% resolve spontaneously within 3 months. But if there's zero improvement by 3 to 6 months, that's when surgical nerve grafting is seriously considered. Sticking with pediatrics, you absolutely need to recognize radial head subluxation, better known as nursemaid's elbow. The vignette is almost always the same: axial traction on an extended arm. Think of a child being swung by the arms or quickly pulled up by the hand. They'll come in holding the arm extended and pronated. But here's the catch. What makes this diagnosis so distinct is what's missing. There is absolutely no swelling, no deformity, and no focal tenderness. It's an instant fix in the clinic. You just do hyperpronation of the forearm or supination combined with elbow flexion, and they're usually back to playing in minutes.
Okay, time for another scenario. A pregnant patient complains of pain and numbness in her first 3.5 digits. What provocative tests are you going to use to confirm your physical diagnosis? Well, that highly specific nerve distribution points straight to the medium nerve, meaning carpal tunnel syndrome. And we lock that diagnosis in clinically with the Fallon, Tinel, or Durkin carpal compression tests. So what exactly happens during these tests? In the Fallon test, sustained wrist flexion physically compresses the median nerve right inside the carpal tunnel. Meanwhile, the Tinel sign is when you lightly tap over the median nerve. If either of these reproduce that unmistakable tingling and pain sensation for the patient, that's a positive test. The reproduction of the exact pain is the whole point here.
Now, you've got to connect carpal tunnel to systemic risk factors. It's not just repetitive strain. Look out for pregnancy, diabetes, hypothyroidism, rheumatoid arthritis, obesity, and ESRD, especially patients on hemodialysis. In severe cases, you'll actually start seeing thenar weakness or atrophy. Management starts simple: wrist splinting and glucocorticoid injections. Only pull out nerve conduction studies if you need to confirm an unclear diagnosis or assess severity right before surgery. Now, real quick before we hit the shoulder, let's contrast median nerve issues with a few other hand and elbow pathologies. De Quervain tendinopathy, that's radial wrist pain with the thumb flexion and ulnar deviation, treated with a thumb spica splint. Lateral epicondylitis, that's pain just distal to the lateral epicondyle on resisted wrist extension from overuse, treated with a counterforce brace. And Dupuytren's contracture? Look for gradual palmar fascia thickening and nodule formation at the 3rd through 5th digits, usually in older men who might have a history of diabetes, smoking, or alcohol use.
All right, let's map out the massive adult shoulder branching algorithm. It is entirely based on your physical exam.
Pain with abduction but a totally normal passive range of motion? You should be thinking rotator cuff impingement, which you confirm with positive Neer or Hawkins tests. What if both active and passive range of motion are decreased? That's either adhesive capsulitis or osteoarthritis. AC joint sprains are different. They'll show pain specifically with crossbody abduction. And don't forget shoulder dislocations. Anterior is by far the most common, presenting with an abducted, externally rotated arm. Posterior dislocations happen after violent muscle contractions like seizures or electrocution, leaving the arm adducted and internally rotated. Oh, and always check the neurovascular status, specifically the axillary nerve, before you do a closed reduction. Finally, what if you see isolated weakness of abduction and external rotation, but absolutely zero sensory loss? That points directly to suprascapular nerve entrapment.
Let's zoom in on the rotator cuff for a second. Tendinopathy and tears can look deceptively similar at first glance. Both are going to present with lateral shoulder pain during abduction and external rotation. You'll find subacromial tenderness, and both have completely normal passive range of motion. So what's the essential test day difference? A rotator cuff tear adds actual, measurable weakness to the equation. Tendinopathy gives you pain without weakness. A tear brings the weakness.
And here is how you test for that weakness. The drop arm test, which isolates the supraspinatus muscle. If a patient, usually someone over 40, cannot smoothly lower their arm from a 90-degree abducted position and their arm just abruptly drops, accompanied by a sharp pain, that's a positive test. You are highly likely looking at an acute supraspinatus tear. Your immediate next step is to grab an MRI or ultrasound to confirm the tear before you even think about physical therapy or surgical repair.
Let's test that logic really quick. A patient comes in with shoulder pain and weakness during abduction, plus, and this is key, sensory loss over the lateral shoulder. Is this a rotator cuff tear? No, absolutely not. That lateral shoulder sensory loss is your absolute pivot point. It indicates an axillary nerve injury. This is a beautiful, classic way to differentiate it from a standard rotator cuff tear, which is strictly a motor and pain issue. The cuff doesn't give you a sensory deficit.
Now, completely contrasting everything we just discussed with the rotator cuff, we have adhesive capsulitis, or frozen shoulder. This presents with profound stiffness that is totally out of proportion to the actual pain. You will see a gradual onset of severely decreased active and passive range of motion. It is heavily linked to diabetes mellitus and hypothyroidism. The diagnosis is clinical. You only really grab imaging if you need to rule out something else like osteoarthritis. Treatment: start with gentle range of motion exercises, NSAIDs, and steroid injections. You reserve things like capsule distension or surgical release only for the most severe, stubborn cases. Okay, let's lock all of this in with a rapid upper limb summary. Normal passive but decreased active range of motion points to a muscle or tendon issue. If both are decreased, you are dealing with the joint. Down in the neonates, herb de chêne leaves the grasp intact, while clump gait completely wipes it out. Up in the shoulder, rotator cuff tears have weakness, tendinopathy only has pain, and axillary nerve injuries throw sensory loss into the mix. If you strip away all the distracting symptoms in a vignette and focus entirely on the core mechanical deficit, the right diagnosis becomes undeniable. So when you're sitting there on test day, look past the noise. Ask yourself, what is the single fundamental loss of function here? Because once you find that mechanical failure, the answer will be staring right back at you.